Good morning and welcome all to today's Breakfast at UMHealth episode 14. I'm Theo from the Department of Orthopedic Surgery, Sport Injury and Arthroscopic Surgery Unit. I'll be chairing the first half of today's session. As our population is aging and the benefit of active aging are widely acknowledged, there's also an increased concern of degenerative changes in our body, especially the knee. A specific injury to the meniscus, which is found in our knee, have emerged in the recent years as another significant driver of a degenerative disease, which is also known as a silent epidemic. Here, I would like to introduce our speaker, Dr. Sugesh. He is a medical lecturer and orthopedic surgeon from the Sports Injury and Arthroscopic Surgery Unit. He will enlighten us with his talk titled Meniscus Root Tear, a root cause of rapid osteoarthritis progression. Dr. Sugesh, over to you.
Good morning to all, and thank you very much to Professor Theo for the introduction. So today my talk will be on meniscus root tears. And like Prof. Theo alluded, meniscus root tears have been increasingly talked about in, at least in the orthopedic circles, in the last 5 to 10 years. And the reason for this is it does cause quite a significant impact on the articular cartilage. And my talk today hopefully will try to highlight the importance of identifying these tears and what is the consequences of these tears on the articular cartilage of the knee. Right. So over the next 10 to 15 minutes, we'll be looking a little bit on the anatomy of the meniscus, what are the biomechanics of the root tears, some etiology and risk factors, clinical presentation, imaging, what are the current treatment recommendations based on the literature, and finally a clinical case example of a patient that we treated in our center. So what is it and why is there all the fuss about meniscus root tears? So the root tear itself actually is not very new. It was first described by Patnani in 1991. It was defined as an avulsion of the attachment or a complete radial tear within a centimeter of the anterior or posterior tibial attachments of the meniscus. So if you can see on the cadaveric image on your right, the meniscus is a C shape and there will be an anterior and a posterior attachment onto the tibia. So this is where the root tears occur. So in the last 5 to 10 years, there is a growing body of evidence showing that these tears cause early and in fact very rapid progression of knee osteoarthritis. And as Prof. Theo mentioned, these tears have been termed the silent epidemic. I have shown here a few of the papers in the literature, so you can see that meniscus root tears, a silent epidemic, solving the silent epidemic. You may not have seen it, but it's seen you. So what it basically tells us that many of these injuries have gone unrecognized due to the fact that we are not aware of it. We are not aware how to diagnose, what signs to look for, and the incidence, it's not low. In fact, in some case series, it's reported to be as high as 21% of all meniscus tears. So going back to the anatomy, I think I won't spend too much time, but I think this picture illustrates the anatomy quite well. So we know meniscus to be a C-shaped structure which is sitting on the surface of the tibia, and the circles represent the root attachment. So you have a C shape and the circles represent the root attachment. And we have root attachments on the anterior side for the medial and the lateral meniscus. And we have root attachment at the posterior side for the medial and lateral meniscus as well. So there are a few types of root tears that can occur. As you can see here, there's a classification by Laprat, which shows there are 5 types of root tears. However, the common one that we see in practice are basically these type 2 tears. As you can see, is instead of an avulsion of the bone of the soft tissue like a type 5, is actually a radial tear which is very close to the attachment of the root itself. So a little bit on biomechanics. So we know the meniscus have very important function in the knee. So it helps to increase surface area of contact and also dissipate hoop stresses while the knee joint is loaded. So to to maintain this function, the roots play a very important role by holding on the meniscus onto the tibial surface. And it also absorbs 50 to 70% of the medial and lateral compartment loads. So when you have a disruption of the meniscus root, it loses this function. And as what happens is your cartilage is now exposed to very high loads and reduced contact area, and eventually this is as in you are losing your entire meniscus. So what are the cascade of events that happens after a root tear? So basically, once you have a root tear, this root tear will increase meniscus displacement and gapping. And what you have is a phenomenon called as a meniscal extrusion. So when you have meniscal extrusion, the meniscus does not sit under your femur and tibia, and this will then increase contact pressures across your articular cartilage, and the end result will be osteoarthritis. So this is a illustration of, you can see on your left is with loading, you can see the meniscus, how it shares and distributes the load. But if you don't have a meniscus, now all those, the surface area is reduced and all the force is concentrated on one point on the cartilage between the femur and the tibia. So, like I mentioned just now, there's a phenomenon called meniscus extrusion. So in meniscus root tests, you do not lose your meniscus, but what happens is your meniscus extrudes out, like you see on the illustration on the right. So what happens when it extrudes out is basically like you are losing your meniscus. So the meniscus no longer sits within the confines of the femur and tibia, and as such, this increases the contact loading between the two surfaces. So how about putting it in numbers? So when you look at the numbers, the normal knee contact pressure is around 3.9 megapascals. But when you have a posterior root tear, this can increase up to 5.1 megapascals, which is a 30% increase in contact pressure. And the surface area with root tears also reduces around 20 to 30% as well. And similarly, we see these findings in the lateral compartment as well. So this is another pressure map, as you can see, comparing total meniscectomy with a root tear. So on your far left is a normal, in the middle is total meniscectomy. So you can see the blue and green represents a high contact load. So you can see a very similar pressure map between the total meniscectomy and also the root tear, showing that it is functionally equivalent to a total meniscectomy. So what are the etiologies? So when we talk about root tears, there are anterior and posterior root tears. So anterior root tears are fairly uncommon. They are usually disrupted, usually iatrogenically during a surgery, like when we are doing an ACL reconstruction due to improper tunnel positioning, or even when you're doing a fracture nailing of the tibia. But in this talk, I'll be focusing more on posterior root tears. And the medial and lateral root tears tend to occur in specific patient population. So this table shows the difference between the medial and also the lateral root tears. So the medial root tears tend to occur mostly in the older generation, 40 to 60 years old. They tend to be degenerative in nature. They tend to have a higher BMI with a varus alignment in their lower limbs, and also tend to occur more common in the females. The lateral meniscus posterior root tear, on the other hand, usually in younger patients, they are traumatic in nature and usually associated with the ligamentous injury. So the lateral meniscus posterior root tears, most of these patients usually presenting to the orthopedic surgeon for ligamentous instability. So identification of these root tears are basically the onus is on the surgeon to try to identify it. But I think so the problem usually lies with the medial meniscus posterior root tears, because this group is, the older group, they don't immediately present to the orthopedic surgeon, and hence, the diagnosis can a lot of times be delayed. So making the diagnosis of a root tear is in fact challenging, and the reason for this because there's no specific history of physical examination to actually guide the diagnosis. And a lot of patients, when they present, the immediate action is, of course, to do the X-ray. And X-ray, you may see some early OA changes. And commonly, these patients are treated as knee-OA, given some symptomatic treatment, and this is one of the reasons there's a delay in the proper diagnosis. The X-ray on your right shows actually is one of a patient who actually had a root tear, and as you can see, the X-ray itself is fairly innocuous, other than maybe early joint space narrowing and prominence of the tibial spine suggestive of early OA. So what about the history? What pertinent history that we can take that would suggest a root tear? So oftentimes, patients complain of posterior knee pain as a primary complaint, and usually this is atraumatic, is sudden, and with a minor activities such as squatting or sitting in a deep knee flexion, okay, and they may recall a precise time point at which this pain started, but a lot of times they may not actually recall this. And some patients may happen to complain of a popping sound during light activities like climbing or squatting. So how about the physical examination? Once again, nothing really specific to point towards a root tear itself, but a majority of them tend to have posterior knee pain, especially with deep flexion. So when you're examining them, whether they're lying down, they flex the knee deep, and they would tend to complain of posterior knee pain. Or if you ask them to squat and they are unable to perform a deep squat because of the posterior knee pain. The other things that can be present is joint line tenderness, effusion, especially if it's more acute, and positive McMurray test, which is a common test that we do for meniscus tests. There is a test that has been described in the literature, quite specific for root tests, where you actually attempt to palpate the extrusion of the meniscus by applying a varus force to force the meniscus out medially, and the examiner can actually palpate this. However, personally, I don't have much experience with the test, and I think in the literature, the reliability of the test is also unclear at this point. So next, we move on to imaging. I think MRI remains the gold standard diagnosis. X-rays, yes, we can't see the root tear per se, but it's still helpful as a preliminary investigation. I think to assess the degree of severity of osteoarthritis. Some of these patients, they present late, and at the time that you may be seeing them, the X-rays may show quite a severe osteoarthritis changes, and long leg alignment views. I think this is valuable as well, as we can assess the degree of varus deformity. So moving on to the MRI. MRI should be obtained. If you suspect a root tear, it should be obtained as promptly as possible, so we can obtain the diagnosis early before the progression of OA initiates. And there are several pathognomonic signs that have been described, and this includes meniscal extrusion, the ghost sign on the sagittal images, high signal intensity of the axial cuts, and bone marrow edema, which I'll go through in the next few slides. So on this slide is basically demonstrating the ghost sign. So yes, you can see on your right, this is a normal appearance of a meniscus. As we see, there is a black signal of meniscus tissue, which we call as a bow tie sign, which is appearing on the anterior and posterior side. But if you look on your left side, the arrow shows that just a white signal here. So there's a loss of the meniscal tissue appearance, and this is described in the literature as a ghost sign. Next, we look at meniscus extrusion. Right? As you can see, this is a coronal cut. So this is the lateral, and this is the medial side. So you see on the lateral side, the meniscus sits within the confines of your margins of the femur and the tibia, whereas on the medial side here, you can see the meniscus is extruded out and out of the confines of the femur and the tibia. And this will then increase the loading, as I mentioned earlier. And as you can see, the evidence of the increased loading is the bone edema, which is highlighted by the asterisk sign here. This bone edema is a consequence of increased loading across the articular cartilage. So how good are we with the MRI identification of these tests? So I think the reason a lot of these even missed it on MRI is many of these patients, especially the older ones, they have a lot of degenerative signs on MRI, and this may actually distract the reader from the actual diagnosis itself. Several studies have shown that the preoperative detection have a sensitivity of only 82 and 60%, and even another study showed a preoperative identification on by fellowship trained radiologists to be only 33%, which is fairly low. So I think the important lesson here is that if the history and physical examination is suspicious, I think we really need to look hard on the MRI images to make sure we do not miss this diagnosis. So what are the treatment options for root tests? So first, we can do a non-operative treatment, right? A lot of these patients, as I mentioned, older patients. I think non-operative can be an attractive option. You just give them physical therapy, unloader brace, analgesics. How well does it work? We will look the next slides. We can also do a arthroscopic partial meniscectomy, which is basically removing the symptomatic portion of the meniscus, or we can arthroscopically fix back the root tear. So let's look at the evidence for each of these. So what happens with a non-operative treatment? So as we mentioned in the biomechanic slides earlier, root tear is equivalent to a total meniscectomy. So the prognosis is generally very poor. Based on the study by Crouch, he showed that not only that they had worsening OA, 31% of the patients had to undergo arthroplasty within 5 years. And in another study by Choi et al., while doing total knee replacements in patients under 60, they examined the meniscus roots and they found that there was a 92% rate of posterior medial meniscus root tears in patients undergoing TKR, which are under 60. And I think this study really makes us think, how many of those TKRs that we are doing in young patients, they probably had a root tear which was, unaddressed. So this is a very nice X-ray showing the consequence of untreated root tear. So the diagnosis was made on X-ray A, and you can see eventually on X-ray E, the patient had to undergo a partial knee replacement. And this is an extreme case where the deterioration happened over just 12 months. And based on this X-ray, you can see what is the severe consequences of a root tear. So how about economic considerations? So non-operative measures, but what we know is it increases the volume of total knee replacement. In the end, a lot of these patients undergo total knee replacement, and that in fact will put further strain on our healthcare system. So this study done in US, and they showed that out of the 31 patients that underwent conversion to TKR, that resulted in a 1.1 billion cost to the society. So surgical treatment is probably better and also cost effective for this group of patients. So similarly, just showing the same X-ray earlier, you can see if this patient is maintained non-operatively across the period of time, there's increasing cost incurred because of medications, injections, and eventually knee replacement, as opposed if we do the surgery at point A and then be one-off surgery rather than undergoing and suffering for the next 12 months. So how about partial meniscectomy? Historically, this is a common procedure that's been done for a lot of meniscus tear. The root tears are considered in one of those group of tears where they do partial meniscectomy. However, literature shows that these results are also poor and they're not superior to non-operative treatment. In fact, one study showed a 35% conversion rate to arthroplasty if you do a partial meniscectomy for root tears. And another study by Crouch was even higher. They found a 52% rate of patients with partial meniscectomy going on to have arthroplasty, and in a very short time, in 4.5 years. And also there were no significant improvement in patient-reported outcome measures. So what we know is non-operative measures and partial meniscectomies don't really work well for this group of patients. So that brings us to surgical repair. So does surgical repair actually help this patient? These older patients, are we doing justice by subjecting them to anesthesia and surgery? So this is a biomechanical study and showing the contact pressures in the medial compartment. So on your this black bar actually shows the pressure within the normal with the root which is intact, and those bars with asterisk are different simulations of a root tear. So one is a root avulsion, one is 3 mm, 6 mm tear, 9 mm tear, and you can see the plus sign is when the root has been repaired. So you can see every time the root is repaired, we pretty much bring back the contact pressures to almost similar to the intact root pressure. So demonstrating that the repair is able to restore joint loads to maybe not fully normal, but at least near normal conditions. So this is a pressure map you can see. The red and yellow represents a very high pressure. So you can see on the intact on your far left, in the center we have a root tear, and the root repair, all those yellow and red signs are almost gone, showing that there's a restoration of contact pressures with root repair. So I think there's one caveat with repair. Repair works best when it's anatomic. If we don't do anatomic repair, as you can see in this study, the non-anatomic repair is the fourth bar chart here, and you can see it does not restore the contact pressures back to normal, as opposed to the anatomic repair, which is the third bar chart you can see on your left here. So what are the techniques for repair? So there are mainly both of these are done arthroscopically, and there are two main techniques where we use either a suture anchor or a transtibial pull-out suture technique. And this is the most common, the transtibial pull-out technique is the most common technique that's been used. And in fact, in PPUM, this is the technique that we are using in our unit. So navigating and within a tight knee space, it's difficult, especially in the older population with degenerative knees. But fortunately, with the evolution of our surgical instruments, nowadays we have better surgical instruments to help us to do these procedures in a much more reproducible and safe manner. We have aiming jigs to drill the tunnels. We have these specialized suture passing devices to help us to pass sutures to tie the root tears. So this is a typical arthroscopic repair of posterior meniscus root. Generally it goes through 4 steps where we prepare the site of repair, we drill the tunnel, we pass the sutures, and finally we tie the sutures on the cortex of the tibia. So on the picture A here, you can see at the top is the femur, down is the tibia. You can see the meniscus is lifted off from the surface of the tibia. So this is where the tear is. We prepare the site of the repair. And we use the jig here to drill a tunnel, and we pass sutures into the root of the meniscus, and then finally you can see here the sutures are pulled through into the tunnel, and you can see the root is pulled back onto the surface of the tibia, like how it's supposed to be. So what are the clinical outcomes? We know the biomechanical outcomes are good. What about the clinical outcomes? So there are multiple studies showing improved patient-reported outcomes. One such study from the US by Laprat, 50 patients of 2-year follow-up, they found that a significant improvement in outcome scores, regardless of age, and a very low revision rate. And importantly, I think they found that whether they operated on a patient less than 50 or more than 50, there is no real difference in the outcome. Lee from Korea, they did a 2-year follow-up, and in fact they went in again. They did a scope and they found almost complete healing in 27 knees who underwent meniscus repair. And I think another study by Korea, I think this one has the longest follow-up, I think up to 10 years. And in 91 patients, they managed to show a survivorship analysis. So survivorship in this study means that meaning none of the patients underwent repeat surgery or were converted towards total knee replacement or partial knee replacement. And you can see the survivorship even up to 8 years is up to 92%. So I think based on these data, doing the right surgery for the right patient, I think can really yield very good results. Most of the studies show significant improved results in terms of patient-reported outcomes and also patient satisfaction. But a lot of the studies are only short to mid-term range. I think long-term studies we are still lacking in the literature. So this is a simple treatment algorithm. So majority of the patients are basically indicated for repair, whether they are acute or chronic. Unless in specific conditions, as you can see, there are some contraindications that are listed in this algorithm. And I think mainly when you have very bad arthritic changes where subchondral collapse or the cartilage wear is already too bad, the X-ray shows, Kelvin Lawrence grade of 3 or 4. So in these kind of patients, we probably have missed the boat in terms of doing a repair. So doing a repair is likely going to fail in this group of patients. However, some of the contraindications here, like BMI, malalignment, I think these indications are evolving as we speak. There are recent studies showing that even in patients with higher BMI, we are able to get good results. So this is a space that is, I think, still evolving. So basically, all patients who are active, regardless of their age, we are indicated for repair based on this algorithm. So finally, I'd just like to share a clinical case. This is a case that we've done here at BPM. It's a 49-year-old, fairly young patient who actually presented to us with 2 months history of left knee pain. And the pain was sudden, it was atraumatic, and it was progressive worsen over time. And this patient was unable to squat and climb stairs. So she was in fact seen in another clinic. They did an X-ray and told her that she had early changes of arthritis, and so she was given symptomatic treatment as well as supplementation for osteoarthritis. So these are her X-rays, and the left side is the affected side. So you can see that there are not many changes on the X-ray, maybe some early osteoarthritic changes. Alignment on the right side appears normal. Given the fact that the pain was progressively worsened and severe enough that she can't squat and climb stairs, we decided to proceed with an MRI. And as you can see in this MRI, these are some of the cuts from the MRI that I took. So you can see on the sagittal there is a ghost sign present, which I showed earlier, which is the absence of the normal meniscus tissue appearance. And then on the coronal slide, you can see the meniscus is extruded as marked by the red arrow. And finally, on this axial slide, you can see a very nice appearance of the meniscus here, but where it is supposed to attach, there's a very high signal intensity, and this is very suggestive of a root tear. So based on these findings, we counsel the patient for a root arthroscopic root repair, and then she agreed. And at 1 year follow-up, she had very significant improvement in the symptoms. She does have on and off pain on exertion though, but her gait is normal and she's able to perform a full squat pain-free. So this image is the patient. She actually just came for PCA yesterday, and this is she performing a full squat without any pain. So in summary, I think what we need is we need heightened awareness of root tests and its deleterious effects. I think is of paramount importance. Not all knee pain in 40 to 60-year-olds are pure knee OA. Always have a high index of suspicion in patients with suggestive history and physical examination. Prompt MRI to avoid a delay in diagnosis. And I think early referral patients to orthopedic surgeon is important. Even in areas where you don't have access to MRI or don't have access to early MRI, I think you should refer these cases to a surgeon who can manage this patient in a more prompt basis. And finally, I think the evidence points that surgical repair can in fact provide excellent short and medium outcomes for this group of patients. And with that, thank you. I'd be happy to take any questions.
Thank you very much, Dr. Sugesh, for the very informative talk. Yeah, I think quickly we move on to the QA. There's a few questions here. The first one is, I think some of them are being answered in your talk, but we just go through them again. First one is, what's the typical duration would you give for non-surgical treatment before you advise for surgical repair?
Yeah, so I think like in my talk, I said non-surgical treatment from the evidence we show does not work. So we really reserve them for patients that are not eligible for surgery for whatever medical conditions, that precludes them from having undergoing anesthesia. And there are some contraindications, and if we have missed the boat, for example, that they come in with very bad cartilage status, or the X-ray shows very bad OA. I think in these conditions we have missed the boat, and only then we will give non-surgical treatment. I think otherwise, I think early surgical repair is the best course of action based on the evidence that we have now.
Yeah, I think that also answers to the questions to how about the age group? Is it below 40s, 50s, and versus demand of the patients and populations that's being asked here? And and same as the next question is an as early as possible surgery repair beneficial? Will it reduce the risk of OA? Yeah, I think we have.
So I think if you see the X-ray progression that I showed in one of my slides, that was an extreme case that even in 12 months that the patient had to undergo knee arthroplasty. So I think yes, early repair as soon as possible is the best course of action.
Yeah. Another very interesting question. Can injection of stem cells improve this medial or lateral root tear?
Yeah, interesting question. So I'm not aware of any evidence of using orthobiologics, whether in terms of therapy or whatever. But I think from a structural point of view, I think if you have a complete tear, I think that requires surgical stabilization, because every time you are loading your knee, that meniscus is going to displace. So I think that itself puts it at a very poor healing environment. So unless you have like a partial tear situation, maybe in those conditions, yes, orthobiologics like PRP or stem cells may help. But if you have a complete tear, I don't have evidence for this, but structurally speaking, I don't think it would work, because the meniscus is just going to keep on moving and gapping. Yeah, I agree with that. We'll move on to the next question. You say here, hi, Dr. Sugesh, love the presentation. Based on your experience, which patient will benefit aggressive management in terms of reducing the progression of knee OA? I guess we have answered that. Yeah. And also the next one is, would you advise for MRI for all patients with early OA that have clinical history and examination suggestive of a posterior meniscus root tear? Yes. Yeah. So I think the second question is a good question. So basically, when shall we pull the gun and order an MRI? So we can't say to order MRI for everyone. So I think, like I mentioned, with this root tear scenario, there is no specific guide. So I think you really need a high index of suspicion. If you see the patient, like I presented, have a very severe pain, but the X-ray is not very severe, just very mild OA, I think in this case, you really have to think of something other than OA, and I think you should order an MRI in these cases.
Yep. And we move on to the next one. In those studies that show good result after repair, do they include or exclude arthritis knee?
Yes. So most of them are the indications for repair, as I mentioned, is yes, they have arthritic knees, but their grade is Calgon-Rollins generally 1 and 2. If it's Calgon-Rollins 3 and 4, what we know from the evidence is they don't respond very well to repair, so we don't include them in the studies.
Yeah. And also, we have three more questions. We quickly go through them.
Right.
Do we augment the repair with rasping or trephination?
All right.
Not technical questions. Yeah.
Yeah. So the repair itself. So one of the benefit of doing these trans tibial technique is when you are drilling the tunnel. That drilling or the tunnel itself will provide a lot of pluripotent stem cells, from the bone itself, and that itself is an kind of augmentation. There are some studies where they further augment by doing a microfracture at the notch to further augment the healing capability of the root there.
And you say, okay, thank you. Another question is partial root tear debridement adequate?
Yes, in a partial tear which is still stable, yes, some studies have shown that debridement is adequate, but you need to be careful that you not to debride too much that you remove the entire root. So a very selective debridement.
I guess we'll finish off our Q&A here. And in case if there's some question that's not answered or we couldn't answer here, maybe you can just email to us or to Dr. Sugesh. He'll try to answer for you. Okay, thank you very much for answering all the questions and thanks for sharing with us. With the interest of time, I think I'll pass on to the second half webinar to our next chair, Dr. Ng. Thank you.
Yeah, thank you, Professor Teo. Hi, good morning, everyone. I'm Wei Leik from Department of Primary Care Medicine. So I'd like to introduce our next speaker, Dr. Amirul Amzar, who is a clinical specialist in our department. So Dr. Amirul will be talking to us about how to communicate with vaccine-hesitant individuals, in which he will be presenting two cases from RUCA. So Dr. Amirul's interest is in health behavior and vaccine communication, whereby he's actively involved in an NGO called Medical Mythbuster Malaysia, who is very active in dispelling vaccination myth, among other medical myths, since 2016, and he's currently the vice president for the NGO. And Medical Mythbusters Malaysia is also involved with the Ministry of Health and our special committee for COVID-19 vaccine during the introduction of our COVID vaccination program to increase confidence among the public. So he has been helping with the vaccine communication training with Ministry of Health since 2018 to address childhood immunization refusal. He has written a book on that and also helping with development of a guidebook. So I think Amirul is the right person today to address this topic today. And Amirul, over to you.
Okay, thank you very much, Wei Leik, for your kind introduction. I will start to share my slides. Okay, so thank you, Wei Leik, for moderating the session. So today, I would like to give a talk about how to communicate with vaccine-hesitant individuals. So I also will share some experience regarding vaccine-hesitant individuals that we have encountered in our clinic. And then I will share some information on vaccine hesitancy and what are the best evidence-based method on communicating with them to convert them into vaccine acceptors. So I'll start with my first case. Madam Eddie is a 71 years old Indian lady who is a retired clerk, previously working in a law firm. She has underlying cholangiocarcinoma, had done Whipple procedure. She also had discoid eczema and also essential tremor. She came to our clinic, requested for medical exemption for COVID-19 vaccination. And the reason for her refusal would be, she said her vaccinated friends still got infected. And also, she's worried that the vaccine could cause allergic reaction and worsen her eczema. On further history, she actually has no medical contraindication for vaccination. The second case is a younger gentleman, a 30 years old Sabahan gentleman who actually stuck at Klang Valley during the MCO. He had recent MVA with spinal and pelvic fracture, causing paraplegia and neurogenic bladder. And he also has underlying major depressive disorder. He came to our clinic, he requested for medical clearance to board his flight despite being unvaccinated. When we asked why he did not want to get vaccinated, he said he had tried. He went to multiple PPV and he was rejected because of his underlying paraplegia and neurogenic bladder, and he was asked to come to hospital. Because of that, he was hesitant and refused to get vaccinated after that. At the same time, he also worried that the vaccine might contain MRSA. The reason why he's worried is because when he was admitted because of the MVA, he had contracted MRSA and also had a prolonged hospital stay. But when we ask further, he actually has no medical contraindication for vaccination. So these two cases are commonly seen during COVID-19 vaccination program, and it is a classic presentation of vaccine hesitancy. By definition, vaccine hesitancy does not only include those who refuse, but also those who delay and even choosing types of vaccination. So, do we call this patient anti-vaxxers? What are the difference? Vaccine hesitancy is not the same as anti-vaccine. And this talk today will focus more on vaccine hesitancy. Who is anti-vaccine? WHO in its guideline to communicate with vaccine in public has highlighted a group that is called vocal vaccine deniers. These vocal vaccine deniers is the one that we call anti-vaccine. They are a group of individuals, very small in number, however is very vocal. They spread misinformation and they undermine the vaccination program via misleading facts, personal attacks toward healthcare workers, and a modus operandi focusing on small groups and working in silo. They are small in numbers but very rigid in their belief. In short, anti-vaccine is those who does not only refuse vaccine but also influence others to do so. Vaccine hesitancy itself is a spectrum. It ranges from those who accept all to those who refuse all, with hesitators in between them. You must take note that the only small proportion that really refuses vaccine, and most of them are actually accepting or hesitant. And in Malaysia, this is quite similar. A survey done by the Institute of Health Behavioral Research, MOH, in 2021 regarding COVID-19 vaccine acceptance showed that approximately about less than 5% who actually refuse vaccination entirely. And it is very important to know who are we dealing with, because the way we talk to them is different. Next, we must also know the factors affecting vaccine hesitancy. In 2018, Cornelia Batch came with a model of 5 Cs, which is the psychological antecedent of vaccine acceptance and hesitancy. It described the 5 factors revolving around vaccine hesitancy. The first C is confidence, which is defined by the trust not only towards the vaccine, but also towards the healthcare workers who deliver the vaccine, and also towards the government or the politician involved, or even the process of manufacturing and developing the vaccine itself. The next C is complacency. It is actually a perceived invulnerability towards vaccine preventable disease. They felt that vaccine preventable disease is not dangerous and vaccination is not necessary. Next is constraint, which is the availability, accessibility, affordability, and other barriers towards vaccination services. Next is calculation, which is the individual's engagement in searching for information. Highly calculative individuals are likely to perceive the risk of vaccination itself, and this can increase hesitancy due to the abundance of misinformation regarding vaccine in the media. And lastly, collective responsibility, which is the willingness to protect others through own vaccination. Another factor that has been described is religious incompatibility, which is very important in Malaysia because we are a multi-ethnic, multicultural, and a multi-religious country. So what is our role? It has been shown that healthcare workers are uncomfortable in talking to vaccine-hesitant individuals. We may underestimate our role as we may be constrained by time, knowledge, or confidence, and sometimes we even dismiss them and give up too soon. However, it has been shown that our recommendation is the major uptake, a major influencer or driver for vaccination uptake. So, we need to realize the importance of our role, and we can do something about vaccine hesitancy. So, how do we start to talk about vaccine? In most of our consultation with patients, we usually use the participatory approach. We ask whether the patient wants to get the treatment or intervention or investigation or not. Do you want to get your vaccination? However, expert and available evidence suggests that using a presumptive approach is more likely to increase the uptake of vaccination. Today, I'm going to register you for COVID-19 vaccination. The analogy is like a parent bringing a child with asthma attack to your clinic. You don't ask them, do you want to get your nebulizer today? You just say that your child needs nebulizer today to relieve from the asthma attack. Same with vaccine. Today, I'm going to register you for COVID-19 vaccination. This is what we call presumptive approach. It does not only increase the uptake for vaccination, but it also helps us engaging what are the hesitancy level. So based on the response, we can actually gauge the hesitancy level, and they will reply differently, and these different replies warrant them into different groups and warrant a different approach. Those who accept all will probably say, yes, I'm ready. Those who accept but unsure will say, I guess I'll vaccinate, but a bit hesitant there. Those who are in the fence-sitter, I'm not sure, I don't know, probably I'll just let others to take first. Those who refuse but still unsure why they refuse will say that. And those who refuse all will say, vaccines are very dangerous and I will never get vaccinated. So there are different approaches to all the groups. Those who accept all, we share our knowledge, importantly about the side effects and pain mitigation, because it has been shown that pain mitigation will increase the uptake for subsequent doses. We vaccinate and then we congratulate them and give appointments for second dose. How about the hesitators? It has been suggested to use motivational interviewing, which I will discuss in detail later. But for those who refuse all, importantly, we must not dismiss them. Explore their concern, acknowledge their concern and decision. Ask for their permission to share your knowledge to complete the knowledge gap, and continuously give your strong recommendation. Importantly, do not dismiss them and leave the door open for discussion. You can even give appointment to this patient to review back their decision later. So what is motivational interviewing? Motivational interviewing is a counseling technique involving a collaborative conversation to strengthen the individual's own strength and willingness to change. And by employing motivational interviewing, we are actually changing from a didactic talk, which we give advice and tell the patient what to do, to a collaborative conversation where we empower the patient to realize their own motivation and barriers towards the change. The four spirits of MI are partnership, compassion, evocation, which we ask the patient to, we trigger the patient to come up with their own verbalization of emotion, wisdom, and motivation. And the last spirit is acceptance, which is very important because we need to support the client's irrevocable autonomy for his or her own way. One of the important concepts in motivational interviewing is ambivalence. Change is hard, often because of ambivalence. Ambivalence is a state where we want two contradicting things at the same time. We want and not wanting to change at the same time. For example, I need this vaccination to continue my life, to go to church, to board the flight, to go to supermarket. But I have barriers to it. I'm afraid of side effect. I'm afraid of the other people who get the vaccination complain of side effects. And I'm also afraid that this vaccine might not work. And in MI, we help the client to realize this ambivalence for them to decide which decision is best for them. And the process sometimes can be uncomfortable because this creates a dilemma, and as they want two compatible things at the same time. Another important concept in spirit of motivational interviewing is evocation, where we trigger the client to come out with their own motivation and barriers towards the changes. And this is best done when the client verbalizes it by themselves. We know what we believe when we hear what we say ourselves. So it is important for the client to verbalize their own ambivalence and motivation to change. We help them to realize their ambivalence, then we help them to verbalize their wisdom and motivation to change, and we let them decide based on that. And bear in mind, motivational interviewing relies heavily on the person's current knowledge about the situation. Hence, it is important to correct any misinformation when you do the consultation. What are the techniques of MI that is suggested to be used in vaccine hesitancy counseling? WHO in its training module suggests these two techniques, which is ORS and also sharing of knowledge with respect. ORS actually stand for a mnemonic of open-ended question, affirmation, reflective listening, and summarizing. The objective of asking open-ended question is to elicit the reason behind vaccine hesitancy. Tell me what you have heard, and the patient will tell you what they have heard. Affirmation is actually to encourage the individuals and highlight their strength, to be positive to the patient. You are concerned about your health. You took time to look for information about vaccine. And then you reflect whatever the patient is saying to you. It can be either simple reflection or complex, where you interpret whatever the patient is saying to you. You are afraid of the side effects. You want to make the best choice for your health, which is we keep on being positive. And lastly, we summarize the interaction and ask for any gap before intervening to the patient. Often when I use motivational interviewing to my patient, things got stuck when they reply with, I don't know. Then you should consider that probably this is a knowledge gap that you can fill. It is important to share our knowledge to fill the gap, but with respect in order to build trust. First, you elicit the knowledge gap. You tell me, what do you know about the side effects of vaccine? Then you ask for permission to complete the gap. That is good. If you agree, I could give you additional information. Then you share evidence-based information. Most of the vaccine side effects are mild and self-limiting. It is resolved within few days, such as blah, 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 blah. And safety health studies have shown that adverse event that is severe is very rare. Then with this new information, you verify understanding and the new planned behavior based on the current information. Given our discussion, how do you feel about vaccination now? Keep on showing empathy and openness to discuss. I am here to discuss other concerns that you may have. Some patients will come with pre-existing information via the internet. So how can we empower them to find accurate vaccine information online? This is some tips easily remembered as 4C to ensure accurate information on the internet that you can share with your patients. 1. Ensure that they get from a credible source. Number 2, ensure that the information is up to date. They get the current information because COVID-19 information is dynamic and it changes day by day. Next, ask them to avoid commercial site. And lastly, ask them to check with the expert because information gathered from the internet does not replace a consultation with healthcare workers. Hence, they must check the fact with healthcare workers. There are some tips in conversing with vaccine-hesitant individuals, be it with your patients, your friends, or even your relatives. Number 1, actively listen to the concern and frame vaccination in a way that matters to them. Number 2, you can use fact, but don't use it too often because too many facts at the same time, it can confuse. Avoid using jargon, use language and content that specifically fit the patient. And instead of using facts, you can change it into a stories because it is very powerful, and especially when it involves your personal experience, because we healthcare workers, we also get vaccinated and we also have our own experience with vaccination. And frame data clearly and positively. Instead of saying that there is 1% side effects of vaccination, you can say that the vaccination is 99% safe. Respect the patient's informed decision, whatever it is, they want to refuse, they want to delay, you respect it because it is their decision. Don't be non-judgmental and be non-confrontational because remember, counseling with vaccine hesitancy is not a debate. And lastly, continuously build trust. Let's get back to our cases just now. So Madam AD actually said, I am scared of the side effect, especially because I have cancer. What if my eczema worsen? But I want to go to the church. They don't let me in without vaccination. So you see, this is what we call ambivalence. They want two contradicting things at the same time. And Madam AD, because also she had this fear of side effects towards vaccination. After explanation about the benefit and risk, in particularly because they will be congregating in the church, risk of infection, especially to her age and comorbidities, she was still undecided. So what I did was I gave an appointment for 2 weeks' time. At the same time, I told her that I'm trying to procure a slot for her vaccination. I will give her a call. So I let her go at home with some new knowledge and also some time to decide. The next day, I was able to get a slot for her vaccination and I called her about it. She actually accepted it gladly and now she has completed her 3 doses of vaccination now. Time with compassionate empowerment of the clients is a powerful tool to change their heart. As for Mr. LL's, he felt that he was treated like a ping pong ball, which in his case, he seems to be angry because he was asked to go here and there. And when he presented to us, Mr. LS actually was seen in our triage counter. And due to the limited workforce during the COVID-19, he was suggested to come for another day. He was angry and he created a scene. Registrar was called, but the situation did not diffuse. And I was called for help. And we managed to find an empty consultation room to counsel him. This is important to find a private area because we need to create a setting which is conducive for the consultation, which is private and protected from external disturbance. After listening to him venting out, I shared some knowledge to correct his misinformation, particularly the MRSA, At the same time, I focus on his anchoring point, which is vaccination is needed for him in order to him to get back to his hometown. And without vaccination, he might not be able to get back to Sabah, and he might get COVID here because he has higher risk, and he might get hospitalized here without no one else to take care of her. So to reduce his constraint, which is his main big issue, I called the PPV straight away on the same day, and I asked for the slot on the same day. And Alhamdulillah, we got the slot and we gave the vaccination on the same day, and he was vaccinated twice, 2 doses before he was able to board the flight. Moral of the story, we should strive to reduce the barrier to vaccination. So the take-home message for my talk today, vaccine hesitancy is a spectrum, and most of them are hesitant and can be changed towards acceptance with some effort. Vaccine hesitant individuals is not the same as anti-vaccine, and we should avoid labeling them and stigmatizing even when they refuse, as this will push them further. Motivational interviewing is a very powerful technique in dealing with vaccine hesitancy, and don't give up on refusal. Leave the door open for discussion and offer to meet again or give appointment as necessary. We can do something about vaccine hesitancy if we choose to do so. So these are the 2 examples of the guides for vaccine communication. On the left-hand side is the COVID-19 vaccination communication module, which is available online, published by WHO. And on the right-hand side is our local guidebook, published by Bahagian Pembangunan Kesihatan Keluarga MOH for vaccine hesitancy among National Childhood Immunization Program, which is towards the parents who are hesitant about their child vaccination. With that, I would like to end my presentation and thank you for your listening.
Okay, thank you, Amirul, for your presentation. So while we are waiting, if there's any questions, we still have a few more minutes left. Probably I'll start the ball rolling. Some would argue that it is pointless to talk to a hardcore person who rejects vaccine, probably what you call as an anti-vaccine. It's better just to focus on those who are just sitting on the fence. What do you think of this argument?
For me, to be fair and to be non-judgmental, we should give everybody an equal chance. And as a clinician, we don't get to choose our patient. We don't get those who actually are hesitators. We might actually get anti-vaxxers coming to our door. So I think it is important for us to equip ourselves with the knowledge and skills in order to be able to manage whatever spectrum they come with.
Oh. All right. Do you think this COVID-19 pandemic has really changed the landscape for the whole vaccine hesitancy and vaccine refusal? People are they more accepting to vaccine nowadays based on your works so far?
I see. I think instead of a change, I would say that it revealed the actual situation of vaccine hesitancy, because even without the COVID-19 pandemic, vaccine hesitancy is there. Since even 2015, we have seen an increase in cases of vaccine refusal and increasing cases of vaccine preventable disease among the children. We see outbreak of measles in Sabah because of vaccine refusals. So these things is there, but some of us actually did not realize that this is an issue. Only when COVID-19 pandemic came and vaccination is there, then there is a hoo-ha in the media, then only we realize that vaccine hesitancy is an issue. And I would like to also say that vaccine hesitancy itself is very context specific. It is specific towards the types of vaccine, it is specific to the country, it is specific towards the localities of the people that we are seeing. So some people might refuse some vaccine and might accept another vaccine. So we cannot just simply say that vaccine refusers are those who refuse all. Vaccine acceptors are those accept all, because it is very dynamic and it is some kind of complex process, and also the way to deal with them is also it should be context specific.
Okay. So Amirul, we have a few questions here. So how about addressing anti-vaccines in social media or public platform? I think this is something that you're always very active in.
Yeah. Okay. So WHO, I think in 2018, has a guideline, best practice guidance on how to communicate with vaccine hesitant individuals in public, which is a bit different because they are focusing more on the anti-vaccine. It is recommended that those who want to engage with anti-vaccine on social media must be media trained, must have some training in some media skills, because your argument is not on one-to-one, it's more on people who are actually reading your arguments. And for me, I think personally, I would still keep my cool and I would still just reply nicely, treat them nicely, and try to correct any misinformation, because my target is not to change the anti-vaccine, but my target is actually to change the people who read our conversation.
Okay, that's a good one. We have another question. So how did you counsel on a patient who is afraid of hospitalization due to side effects? Because I have a similar patient who is worried he has no one to take care of him.
Like I said, vaccine hesitancy itself is a very complex, and the reason why they refuse is also very complex. Again, we get back to the basic. When we ask them, we gauge their hesitancy level. Are they the hesitators? Are they the refusers? Okay. And when you try to counsel, when you try to reason with them, you ask for the barriers, you ask for their motivation to get vaccinated. Over time, usually they will change to acceptance, because you build your rapport with them, you build your trust with them, you correct any misinformation. Because in the end, if he got admitted because of COVID also, he also won't get someone to take care of him. So it's actually balancing between the risk and benefit, and we must convey them to the patients, and so that they can make the best decision for them.
Okay, so Prof. Sarah agreed with your comment to be more non-judgmental in all situations. So well done for that. So next one, how do we go about counseling vaccine hesitant pregnant mothers who use the excuse of husband or family refusal to take vaccine?
Okay. So usually, my experience in counseling this type of mothers who actually in KK, usually I will ask for the husband to come together, because we can do couple counseling. But most of the time, the husband will just hide at home and won't come to us. So this is quite difficult, especially in our culture, because our culture is a little bit paternalistic, where we rely on the decision of our husband, especially for the Malays. But then, from religious point of view, I still remember there is one talk by our Mufti Terengganu previously, Datuk Sri Hadi Awang. He said that there is no necessities to follow the husband in things that is dangerous for the wife. So sometimes you might need the involvement of religious people to change the mindset of cultural context, things like this.
Okay. So Prof. Sharifah, thank you for the fantastic talk. And she'd like to ask, perhaps you can share your experience with any. How do you tackle a person who is already hesitant and later had issues post the first dose, which is probably unrelated to the vaccination? So it may not be easy to convince them that the issue is not entirely related to the vaccine, because we see it quite often in our clinic nowadays, right? Everything is tied to the COVID-19 vaccine. Perhaps you wanted to share your experience how to tackle it.
Okay, from what I see from a general point of view, vaccine hesitancy itself, like I said, is very context specific. The patient might accept for first dose, second dose, then suddenly they want to accept booster because they had bad experience with the primary doses. So in this case, the approach is still similar. You gauge the hesitancy level at that current time, and you approach based on the hesitancy level at that current time. And for me, my aim is not to convert them at the same time. It's not to say that when the patients come out from my clinic, they will accept vaccine straight away. Sometimes the process takes some time. It takes multiple follow-ups, and as you build trust with them, as you correct their misinformation, as you show that you are compassionate towards them, and be more like a friend, be more like a people who wants to share correct information and accept whatever their decision, usually that will work, because we are dealing not only with medical things, but we are dealing with human behaviors, and changing human behaviors is not a simple matter.
Yeah, I agree that the trust between the patient and the clinician is an important key point to kickstart. Right? So the next one is, so would you use the opportunity that if a patient has had a COVID-19 infection, would you use it as a chance to encourage patient to receive vaccine or booster? Do you think this approach would be useful?
Yes, actually, but depends on the patient. Sometimes certain patient, when they get COVID-19, their mood is very low. They feel defeated. They felt very anguished because of the infection itself. But probably at that time, it's not suitable to discuss about vaccination. So similar with similar with my talk, what I would usually is I would invite them to talk. Probably I will just ask, what do you think about vaccination? Instead of saying that, okay, now you got COVID-19, you must get vaccination for you not to get another COVID-19. So try to invite them into discussion rather than telling them what to do, rather than doing the didactic talk. Just try to approach a more collaborative conversation.
Okay. So the next one is an interesting one. Amirul, when will you give up, or do you give up at all in giving advice on vaccination if patients still refuse the vaccine despite all you did?
Yeah, I can still remember that I am very ambitious with anti-vaccine, but then at some point of time, I feel like giving up. But then sometimes you don't have the opportunity, you don't have the luxury to be giving up because the patient will keep on coming to you. Just give an appointment, probably when you are a bit more calmer and you are more having a more strategy to discuss with them. So I would say that probably I wouldn't ever give up lah, but yeah, it depends. Sometimes yes, because we doctors as you are human also. Sometimes we have our limitation as well.
Okay, right. So we have a comment here that I have a lot of patients who mentioned that I got diagnosed with cancer after vaccination. I suppose, how do you respond to that? I suppose this is quite similar to what you answered before, right? The patient seems to associate everything else with the vaccine. Do you have anything to add to this comment?
I think still the same. Offer to correct them misinformation and try to engage them back. If they don't trust you, you cannot do anything about it. Just keep on, continue to build rapport and trust.
Okay. So I think probably we will address this as the last question for today, as the time is running short. How would you address the hesitancy arising from viral videos, which claims that others have serious AEFI? So therefore, now the individual is reluctant to receive vaccinations.
I see. Okay. This is a complex situation where we should not be working alone in handling this. The government and maybe the policymakers should have a policy in order to mitigate this issue, because countering vaccine hesitancy is not the job of one person, but it's actually a collaboration between all the healthcare workers, even from public health settings, even from primary care, even from the hospital, tertiary care as well. So actually we need to work together, especially in things that is being disseminated in the media. So probably we need interagency intervention as well. Probably we need to involve MCMC. So I believe the government is doing it right now, but it not be as easy as it seems, because most of our platform for dissemination like Facebook, Twitter, Instagram, and all that are third-party platform, which we don't have a really strong jurisdiction. MCMC doesn't have really a strong jurisdiction on them. And because this viral issue, as the name implies, viral, it is very fast. So in order to us to counter them, sometimes we are not fast enough to counter them. So that is why probably when you are involved with an NGO, then probably you could contribute something in order to dispel this misinformation.
I suppose that's where your medical mythbusters Malaysia comes in. Okay. So I think time is running short now. So thanks for your sharing today, Amirul. And
Thank you, Wei Leik.
You're always active. Please keep up your effort to address the vaccine hesitancy in our community. And hope that our vaccination rate for COVID will improve, especially for the kids. Okay.
Inshallah.
All right. And thanks everyone for attending the talk and for staying until now for the Q&A. Appreciate that. Okay. Goodbye.